Hi. Now we are going to talk about the second part of the acid-base balance and its disorders. So the normal pH is 7.38 to 7.42. So it's a very narrow range. So what is the maximal and minimal pH that can be seen? Around the 6.8 to 7.8. Below that and above that, life is not compatible. As I said, enzymes, they does not work when they are not completely charged. When pH is altered, they may be either negatively charged or they may be positively charged. So what happens? The pH, they won't work at the optimal speed, so we will die. So, as I told you, blood buffers and kidneys and the respiratory system, they maintain our acid-base balance. When any problem with these three systems occurs, or when any increased production of acid or bases occurs, then it may lead to acid-base imbalance. But the body has some compensatory mechanisms. We will see what are the errors that can occur and how body compensates, and above which what treatment is to be given, and that we will see. First, some terminologies you have to understand. One is anion gap. So what is the anion gap? The sum of the cations and anions in ECF is always equal to maintain the electrical neutrality. See, there is no anion gap. It is a myth. The number of cations is always equal to the number of anions in the extracellular fluid to maintain the pH of 7.4. So what are the major cations? Positive ions are sodium and potassium. Chloride and bicarbonate amounts to 86%. And remaining cations and anions we will see. See, the major cation is sodium and potassium, and major anion is chloride and bicarbonate. So there is a difference. It's called anion gap. The unmeasured anion constitute the anion gap. This is due to the presence of protein anions like sulphate, phosphate, and organic acid. The value is 12 millimole per liter. You can understand by seeing the calculation below. So difference between sodium plus potassium minus bicarbonate minus chloride. So measured cations is sodium and potassium. Measured anions is your bicarbonate and chloride. And there are many unmeasured anions are there, that is sulphate, phosphate. But this difference is called anion gap. Measurement between the measured cations and the measured anions. So what are the four types of acid-base disorders? Acidosis. What do you mean by acidosis? Accumulation of acid or loss of base and leading to reduced pH. Two types of acidosis are there: metabolic acidosis and respiratory acidosis. What is alkalosis? That is the deficiency of acid or accumulation of bases. Two types: metabolic alkalosis and respiratory alkalosis. So read this case history. A diabetic patient with uncontrolled blood sugar leading to ketoacidosis. His body acids are increased. He is in ICU and he has heavy breathing. We commonly encounter this uncontrolled diabetes mellitus. Patient will be bored taking of medicines or insulin. So they have very high diabetes blood sugar levels. So what happens? This glucose cannot be used by the cells because insulin resistance will be there or deficiency of insulin will be there. So the body will be starting breaking down your fat, body fat for production of energy. Body fats burned by ketosis, production of acetone, acetoacetate, beta hydroxybutyrate, acetoacetate, acetoacetic acid, beta hydroxybutyric acid. So they are acids. So it will lead to acidosis. pH will reduce. So his body acids are increased. Yes, I accept. He is in ICU. Why he is in ICU? Because he is having heavy breathing. He is having hyperventilation. Why? Why he is having hyperventilation? That is the point. So this problem is called metabolic acidosis because his acid production is more. This keto acid production is more. So it is from the metabolism. So we call it as metabolic acidosis. Acidosis is the pH reduction less than 7.38. Metabolic acidosis is primarily due to base deficit. That is, we have alkali reserve, bicarbonate. This bicarbonate will be destroyed by acid because a lot of production of H plus ions, it combines with the bicarbonate to get neutralized. So the bicarbonate deficiency will occur. So it's called base deficit. What happens here? You can classify metabolic acidosis based on anion gap. So what is the anion gap? We have seen measured cations and measured anions. So anion gap is nothing but unmeasured anions. The normal value is 12 mmol per liter. Based on that, you can classify metabolic acidosis into two types. The first type of metabolic acidosis is high anion gap metabolic acidosis, HAGMA, like Rajma, HAGMA. It is because of accumulation of acid anions. What happens in renal failure? What happens? Your H plus excretion is reduced. So H plus will be accumulated in the renal failure, leading to metabolic acidosis, diabetic ketoacidosis, where ketoacid production is more, and lactic acidosis. Lactic acid accumulation. Now, what happens here in hypoxia, circulatory failure, many drugs and bacterial metabolism, they can produce a lot of lactic acid. Even methanol and ethanol poisoning also causes lactic acidosis. So this is one type of metabolic acidosis called high anion gap metabolic acidosis. So we have seen this high anion gap metabolic acidosis, where the difference between the positive ions and negative ions is huge. Why? Because when acid production is more, it eats up a lot of bicarbonate. So the bicarbonate number will be less. That is the reason for the high anion gap. But you see here, it's a normal anion gap, the second one. It happens in diarrhea. So diarrhea, what happens? The bicarbonate secretion from the intestine will be lost. Here, in the blood, the bicarbonate levels will be normal. So there won't be any difference. Or both cations and anions, they both are lost. So it looks like a normal level. The anion gap is normal, but the pH will be reduced. And another thing is hyperchloremic metabolic acidosis. It happens in an autoimmune condition called renal tubular acidosis. It's where the excretion of acid or conservation of bicarbonate is deficient. And there is one drug called astazolamide, diamox. There is one diuretic. It will lead to this normal anion gap metabolic acidosis, also called NAGMA, NAGMA. So these are the two types of metabolic acidosis. So what does our body does to compensate this metabolic acidosis? So problem is with the increased production of acid or lot of loss of bicarbonate. So here the compensation is done usually by the respiratory mechanism. What happens in diabetic ketoacidosis? Did you remember case history we have discussed? The patient was having hyperventilation. Why? Because he is excreting a lot of carbon dioxide. Where does the carbon dioxide come from? H2O plus CO2. H2O plus CO2 comes from H2CO3. Where does the H2CO3 come from? H plus plus HCO3 minus. So this is how H plus is excreted by respiratory compensation. It's called hyperventilation. It's also called in Kussmaul's breathing this diabetic ketoacidosis and renal compensation. The increased excretion of acid and conservation of bicarbonate occurs. So this sets in 2 to 4 days. So immediately you will have this hyperventilation followed by renal compensation. We will come to the next case history. Asthma and COPD. A patient having asthma, what happens? He can breathe in. Inhalation will be easier, but exhalation will be difficult. So it's called obstructive disease. Exhalation will be difficult. So what happens inside him? Carbon dioxide will accumulate inside his blood. So it's called hypoventilation. So what happens when carbon dioxide increases? Think. So carbon dioxide becomes CO2 plus H2O becomes H2CO3. H2CO3 is carbonic acid. So the pH reduces. So this is called respiratory acidosis. These are the few common causes of respiratory acidosis. Hypoventilation, pneumonia, bronchitis, asthma, COPD, when you give some sedatives, and paralysis of the respiratory muscles during anesthesia, brain tumor, head injury, ascites, peritonitis, sleep apnea. So these are the problems where hypoventilation will be present. So CO2 accumulates leading to respiratory acidosis. So what happens in respiratory acidosis? Because of hypoventilation, PCO2 increases. Most of this PCO2, CO2 becomes H2CO3. So pH reduces. So how it is compensated? See, respiratory compensation is not possible here because the patient is having problem like a COPD. Problem is in the respiration. Then how the respiratory compensation can occur? So the kidneys has to compensate. So how they will compensate this respiratory acidosis? By removal of more acid and conserving more ammonia. So CO2 goes into the kidney, becomes CO2 plus H2O becomes H2CO3. H plus is exchanged for sodium, and the bicarbonate also enters. If you remember the last class, we will know how kidneys compensate this respiratory acidosis. So in acidosis, there will be hyperkalemia. There will be hyperkalemia. Why? Due to high serum levels, the intracellular, the cells, they try to compensate this high H plus by taking up that H plus and releasing potassium. So hyperkalemia will be there, but the problem is intracellular hypokalemia. It is very dangerous. So medical treatment is needed to manage this acidosis. So this is another small case. Okay, a patient is having severe vomiting and he has shallow breathing very slowly. Why? Think. So vomiting, what does the vomitus contain? Acid. Vomitus contain acid. So what is the problem here? The patient is having acidosis or alkalosis. Patient is having alkalosis. Yes. So what kind of alkalosis is this? Metabolic or respiratory? There is no lungs involved. So it is metabolic alkalosis. So, okay. Why he is breathing very slowly? See, the metabolic alkalosis, it will be compensated by lungs. What does the lungs do? It has to conserve the acid. So it cannot excrete CO2. So CO2 will retain. There will be hypoventilation. So when CO2 retains, it will become H2CO3. H2O plus CO2 becomes H2CO3. It becomes H plus. So what happens? Automatically the pH will try to come to normal. So that's why in severe vomiting, breathing will be shallow. So metabolic alkalosis, the problem is excess of bicarbonate since acid is lost, which is compensated by hypoventilation. So PCO2 increases and becomes H2CO3. So common causes are vomiting, hypokalemia, Cushing's syndrome, and diuretic therapy. Because excess of bicarbonate is the basic problem here. So we come to the last part of this chapter, respiratory alkalosis. So because high altitude, there will be hyperventilation. So what happens in hyperventilation? A lot of CO2 is lost. Hysteria, this is the common condition we see in the hospitals. Very young girls, 17, 18-year-old girls, 25-year-old married women. They come with a lot of breathing into the casualty. Simply ask them to take some rest, it will be okay. Or we have to breathe through the bag, paper bag. So there is another physiological importance of breathing through the bag. So in hyperventilation, when they breathe through the bag, they will keep on breathing carbon dioxide. So what happens? The breathing will become reduced. So here in high altitude, there will be hyperventilation. hysteria, septicemia. You see septic patients, they have temperature will be high, lot of breathing will be there, salicylate poisoning. So what happens? CO2 is lost because of that pH level reduces, carbonic acid is lost. So here PCO2 will be reduced. It will be compensated by kidneys. How kidneys will compensate? By reducing the excretion of H plus and reducing the reabsorption of bicarbonate. So this is how respiratory alkalosis is managed. So this is the end of the acid-base disorders. Very important chapter. And at the NEET PG exams, people are very happy to ask questions in the metabolic acidosis, alkalosis. They will just give a table, okay, pH, PCO2, and PO2, like that they will give. Bicarbonate level they will give. What is the disorder? You have to four options will be there: compensated metabolic acidosis, uncompensated metabolic alkalosis, partly compensated metabolic alkalosis, all these things. So you have to read this chapter again and again during the PG times. Now this is a very important UG question also. So thank you. Read every day. Bye bye.